That looks great.
Okay. Well, I'm super excited to speak to all of you. This is such an exciting experience for me. I love cancer research. I'm a big time nerd, so this stuff is really interesting to me, and and I also enjoy teaching. So this is kind of merging my two favorite things together. Um, so what I'm going to present today is really just a snapshot of everything that we have going on. But this part is a part where the patients have a pivotal role, and without the patient's help, none of this would be possible, and we just wouldn't be able to make any of the strides that we're making in cancer research, and specifically multiple myeloma research. So I just want to briefly introduce the research team. We're a small team, but we're a mighty team. So we have Thomas Molina. He just graduated with a bachelor's in bioinformatics. And we have Emily, and she is a biostatistician, and she is currently working on her master's. Both of them are just incredibly smart, great in what they do, and really help us in our analyses and in our research process. A little bit background about me. So as Audrey said in the introduction, I was diagnosed with acute lymphoblastic leukemia when I was just 16 months. I underwent treatments until I was 3, and then I was pronounced cure. And I was really too young to celebrate. I didn't know what was going on, but my parents and family celebrated. And not even a year later, I relapsed and underwent treatments again for additional 4 years. So here you're looking at pictures of me when I believe I was 2, 4, and 6. I still had pretty vivid memories of being in the hospital, my overnight stays, being hooked up to my IVs and receiving my chemotherapy. So I can still very much sympathize with patients and the treatments that they're enduring and going through. Maybe another time I can tell you we can share war stories. I can share you some experiences of my hospital stays. After being a patient, I wanted to fight or get back at the cancer that attacked me. So I got into cancer research. As an undergrad, I reached out to a lab and told them I was interested in doing cancer research, and they welcomed me with open arms. And that's when I got my first exposure at the University of Utah. And then I pursued a doctorate in cancer biology. This is me working in a lab. I love the feeling of working in a lab. I felt like I was a real scientist. I would often put on a coat, even when it wasn't required, just because, that's how you imagine scientists. And it was just a great time, great experience. I learned a ton. I defended and graduated, which was an exciting time as well. I had the lovely support of my wife through it all. And then I went to the Huntsman Cancer Institute and I continued my research, and I did a year-long postdoc there. And when I got done, I wanted to step aside from the bench and just try my hand on data analysis and doing research in that regard. And so I put feelers out there, and serendipitously I got put in contact with Paul Ostrom, who is Jenny Ostrom's husband. Fantastic couple, which I think many of us can agree with. But they brought me in, and my interpretation is they basically hired me on the spot. I was just so compelling, and it's been just an incredible journey working here at the Healthtree Foundation. I've absolutely loved it. So it's a real privilege to me to say that I've gone from patient to researcher. So here at the Healthtree Foundation, we conduct research in one of two ways. So one way that we do it is we acquire the patient information, so the medical health records, and this can be done in a couple of ways. So a patient can input the information, they can give us permission to download their medical health records. Whatever the way is, it goes through a verification process. We want to make sure that the data that's being input is accurate. That's really crucial for research. We can't be publishing results on misinformation. So everything gets verified. And then as a result, patients can then view it, they can interact with it on Healthtree Cure Hub. All of it gets stored in the Google Cloud storage, and this is a very safe location. We understand the importance of keeping patients' data and patients' information safe. We treat it as something sacred, and so we store it in the Google Cloud storage. Google Cloud is also used by big banks, it's used by the government, so it's a very reputable place, very secure. And from there, once it's stored there, we are able to access it and mine it, and we can ask certain questions. So if you recall, a patient will input their genetics, they'll input their treatments that they've received, and we can then ask questions like these that are listed here. Patients that have a specific mutation, what is going to be the best induction treatment for them, or what's going to be the best overall treatment pathway for them? And since we have this information, we can ask these questions and we can get some answers. We also ask some other questions that you may wonder why we're asking, and we want to find out. We ask questions about certain environmental exposures, and we want to know if those have links to contracting or developing multiple myeloma. The other way that we conduct research is we collaborate with a multiple myeloma specialist, and together with them, we put together surveys and studies. Sometimes we do this. This is stuff that we develop, but most of the time it's in collaboration. We then propose this surveys and studies to patients. They complete the surveys and studies, and then we mine their responses. Some of these you may be familiar with. We asked a survey about COVID and how it affected multiple myeloma patients. As a result, we looked into whether lenalidomide protects patients from multiple myeloma. Let me rephrase that. Does lenalidomide protect patients with multiple myeloma from contracting COVID? We asked questions to gain insight about nutrition, about exercise, and all this is really beneficial because this is real world evidence. So data is good, but it's limited. It's limited to what's on the page, where patient experience, patient knowledge is more extensive. So I want to give some examples of studies that we've done using our one of two research approaches. So the first option of when we mine the data. So we looked at VRD and CyberD. They are common treatment lines for newly diagnosed multiple myeloma patients. So utilizing our data, we compared these treatments to identify the optimal induction treatment depending on mutation. Basically, we asked which is better, VRD or CyberD, and does it pertain to, or does it depend on which mutation that you have? So we looked at this comparison, VRD versus CyberD, and we looked at all mutations, regardless of what the mutation type was, we compared it. And what we found is that sorry, I skipped a slide. There was a little lag there and I skipped this slide. So before I show that slide, our methods were that we measured the time to next treatment. Because we're working with patients that are living, we can't look at a survival time from start to death. Instead, we look at a progression time, and that's measured from time to next treatment. This is our proxy for relapse. The patient may not necessarily have relapsed, but it's a good indication of whether the myeloma is progressing or not. So what time to next treatment is that you start the measuring point from the start of the first treatment to the start of the second treatment. So it's not just this from start to finish of one treatment, it's the start of one to the start of a second. If that information wasn't available for our stat analysis that we ran, we looked at the date of last contact. Okay, now back to this slide. So we looked at VRD versus CyberD and all mutations. So regardless of a specific mutation, we found that the time to next treatment is 41% shorter if a patient receives CyberD instead of VRD. Sorry, I'm just gonna adjust my screen. So I understand that many of you may not be familiar with the figure that you're looking at on your screen. So let me explain some of the components. So the y-axis is the survival probability. And what that means is that at time point 0, when we started the analysis, there was 100% survivability, or as we looked at it, 100% zero progression. So nobody had progressed at that point. But as time goes on, and time is our x-axis, and this is in days, as time goes on, we start to see at each drop is an indication of a patient progressing. So as time goes on, an ideal curve would be a flat line, right? Everyone gets a treatment and nobody progresses. But the reality is that patients relapse, but we want to try to delay it as much as possible. So we want this curve to not be steep, but rather more flat or linear. So when we look at this curve, we see that VCD, or patients that were treated with VCD, excuse me, let me say that again, CyBorD, we worked with a team from BYU and they interpreted it as VCD, but VCD is CyBorD. So I apologize if I confuse that. But the patients that received the CyBorD did not, or relapsed sooner. They did not have a progression-free survival time as much as the VRD group. Now, these numbers over here, we have a Cox is the name of the statistician that came up with this model. We have the hazard ratio. So if the hazard ratio is 1.0, that would indicate that there was no difference between the two treatments. But since we have a hazard ratio of 0.59, that's basically telling us that patients that receive CyBorD, their time to next treatment is 41% shorter, right? So 1 minus 0.59 equals 41, so 41%. Our p-value is probability. Now, I have a slide for that. Let me explain probability a little bit. So probability is also known as the p-value. So if I had a coin here and I wanted to determine whether this coin was fair or biased, I could flip it. And we know that it's two-sided, so there's a 50-50 chance that it'd be either heads or tail. So if I flipped it 20 times and I saw 10 times heads and 10 times tail, I would have a ratio of 50-50. And that would fall right here in the middle and that would tell me that this coin is fair. If the ratio was 60-40 or even 70-30, I could still reasonably say that this coin is fair. But as I start to go out a little bit further and start to see a ratio of 20-80, 10-90, or 0-100, then I can start to reason or suspect that this coin is biased because the probability has dropped too low. So basically what we're saying is that if a p-value is less than 0.05, then what we're seeing is not just by chance, but that there's actually a significance occurring here. So back to this figure, VRD versus CyBorD, all mutations. Time to next treatment is 41% shorter if a patient receives CyBorD. That p-value is less than 0.001%. So it's a very significant finding. And the hashes that you're seeing, these little perpendicular hashes on the curve, are either indications of no further contact or no further data. So it's really helpful for us when we have patients not only come in and share their data, but they come back frequently and update their data. Well, now we looked at some specific mutations. So we looked specifically at patients that had at least a translocation 1114. And we found that the time to next treatment for these patients is 56% shorter if a patient receives CyBorD instead of VRD. The probability of this happening is less than 0.01%. So very, very significant as well. We looked at patients with a 1Q gain. The time to next treatment for these patients is 45% shorter if a patient receives CyBorD instead of VRD. And again, the probability is less than 0.05. So again, we found a significant finding. Well, so does this mean that every mutation that CyBorD is inferior? Well, we don't know yet. So we also looked at 414. 414 is a high-risk mutation, or is considered a high-risk mutation. And we found that the time to next treatment was not significant. But the reason for this is because our patient population is too slow. So one thing I haven't explained about the figure on the side is this bottom part. So we have the total number at risk. At point 0, we had a total number of 45 patients. 10 of them were on the CyBORD, 35 were on VRD. And that patient population is just too small for us to gain any real significance to get a real definitive answer of whether one treatment is inferior or whether one treatment is better than the other. So we have 140 patients in our database with a 414 mutation, but only 45 of those patients have sufficient data to be analyzed. So we need the patient's help, especially those with a 414 mutation, to input their data or to allow us to access your medical records and input the data. And that will start to help us identify optimal treatments, optimal induction treatments, optimal treatment pathways for all mutation types. Our goal is to be able to say, okay, you have a 414 mutation. This is the treatment pathway that's going to be best for you to increase the longest survival probability. So we currently have our Healthtree patient experience team that is reaching out and contacting patients. We also have a study that we're conducting that's it's a genetic study using real-world data. And we're actively recruiting patients to complete their genetics, their treatments, to help us find answers for these treatment questions. So who's even being prescribed CyBORD? In the instances that we did find, it was inferior. So who's being prescribed this? Well, CyBORD does work. It's been used on patients, it is effective. But from what we find, it may not be as effective. And the patients that are being prescribed this are those that are seeing a general oncologist. So something that you may hear Jenny Ahlstrom say time and time again is see a specialist, go see a specialist. And that's because they specialize in treating patients with multiple myeloma. They see multiple myeloma patients much more than a general oncologist, and maybe more well-informed with the treatments and the possibilities available for multiple myeloma patients. Okay, so option 2. Option 1 was when we mine the data that patients input from their medical records. And it's so exciting. There's so many questions that we're trying to answer. And we have more questions in the pipeline. So hopefully we'll get to those as quickly as possible. The other option is patient participation. So these are the surveys and studies that we collaborate with specialists and offer to you to participate. You may be familiar with this one. This is one that we collaborated with Dr. Shaw on nutrition perceptions and practices. So a little bit of background about the study. The reason that we wanted to conduct is that patients often have questions on the role of nutrition and whether they should alter food habits. There has been some epidemiological studies shown that inflammatory and insulinemic diets are linked to plasma cell disorders. Multiple myeloma falls underneath that category of plasma cell disorders, while vegetarians and vegans have a reduced risk of these disorders. MGUS and smoldering patients present unique opportunities for early intervention. Essentially, we're hypothesizing that if we propose to these patients, these MGUS and smoldering patients, maybe we could delay the onset or the progression from these precancers to multiple myeloma. While many are interested in, there are many patients that are interested in learning how to eat healthfully. That seems wrong. Oncologists frequently are not prepared to address these concerns. So we asked, if you participated, you may be familiar with this, but we asked participants, have you had questions or concerns about diet and nutrition? And surprisingly, 82% said yes. We then asked, which statement best describes your experience discussing diet and nutrition with your oncologist/hematologist? And a majority actually said that their hematologist or oncologist did not address it. And a surprising number said that their hematologist/oncologist did not address it despite asking. So we found that to be actually quite surprising. So what do they do? If the doctor doesn't talk about it, or if the patient asks and the doctor doesn't respond, what does the patient do? Well, nearly half say that they go and they get diet information from online, television, books, magazines, and other media. This may not be wrong. It may be a good or appropriate diet, but is it the best diet for that patient? And that, I think, would be determined by their hematologist slash oncologist. So as a result, we do see that patients improve their diets from unhealthy to healthy between pre-diagnosis and post-diagnosis. This increases 13%, which is good. But we predict that if we can engage doctors or encourage doctors to discuss diets and nutrition with their patients after diagnosis, that we'll see this increase or this shift from an unhealthy diet to a healthy diet increase even more. So we found that patients that get professional guidance make healthier switches. And we also found that, or we also concluded that this survey depicts a missed opportunity between patients' need for dietary advice and the potential for oncologists to provide helpful counsel. So another study that we did was with Dr. Michael Thompson. Now, all these doctors are great. We love working with them. They're very passionate and compassionate. So they have a lot of compassion for the multiple myeloma community. So Dr. Thompson asked, infection, or the background to his question is that infection is a major cause of morbidity and mortality in multiple myeloma, and that vaccines are the first line of prevention for common infection diseases, but have had variable and low use rates in multiple myeloma patients. So Dr. Thompson was actually conducting this study. He was doing it the old way. And he was doing it by physical copies. When he would get a patient that would come into his office, he'd hand him the survey and ask him to complete it. And so we offered, well, what if we take this survey and we offered it through Healthtree Cure Hub? And he said, sure. He loved the idea. He was really excited about it. But none of us anticipated the outcome. So when we posted it, we had 458 participants in just 2 months. And he said that if he wanted to get that kind of participation in the old way that he was doing, it would have taken him 2 to 3 years. So our goal of accelerating multiple myeloma research is being obtained in that this process and this ability to reach hundreds of patients in such a reduced amount of time is amazing, is really incredible, and is really changing how research is being conducted. So the results to his study, well, he found that it's not as strong as it should be. So not as many patients are getting vaccines as they should. Now, this is a published result. We published it with ASCO. So you can find it online if you search Dr. Thompson or my name and ASCO. But there's the different vaccines here listed on the top. Those that said that they haven't received, those that received either which kind of vaccine or which dose they received, or with where they're standing in regards to vaccine. But I have another study I'm going to talk about, so I'm going to move forward. So this was a really popular study that we conducted, popular in that we had a lot of participation. And this was our multiple myeloma and COVID-19 study, just glancing at the clock. Okay. So many of you may be familiar with this study because you participated. Hopefully you're familiar with it. We love participation. And the background to this is that patients with multiple myeloma are uniquely susceptible to viral and bacterial illnesses. I'm doing a little shrug because you know that. You know that you take extra precaution and whatnot, but multiple myeloma treatments lead to immune deficiency, putting patients at a high risk for infection, including COVID-19. We did a two-part study. In part one, we had 1,358 participants from April to June 2020. We call that the acute stage of the COVID-19 pandemic. In part 2, we had 991 participants from February to June 2021, with 553 participants being returning participants, which was great. So 56%. So we were able to capture how COVID affected them in the acute stage and in the chronic stage of COVID-19. So these are some of the results from that study. We asked, since March 2020, have you or a family member tested positive for COVID-19? There were 64 patients that said yes at the time of that we put this figure together, and 201 of their family members had been diagnosed with COVID. That equates to 7% of patients that participated, and 20% of their family members tested positive for COVID. Of those 64, so looking specifically at those that tested positive, we asked about what their experience was like with COVID and whether they needed to be hospitalized. 17 of the 64 patients needed to be hospitalized. Of those 17, 3 required ICU care. I do not recall any of them passing away. 151 patients indicated that they delayed, postponed, or stopped a multiple myeloma treatment as a result of the COVID-19 pandemic. And the most common treatments that were delayed, postponed, or stopped were Darzalex, Revlimid, and a stem cell transplant. But you can see the other ones that were affected as well. Only 9 patients indicated starting a new treatment. The treatments that were started, 4 started daratumumab, 2 started eximib, 2 started lenalidomide, and 1 started carfilzomib. We wanted to know if patients were receiving the vaccination. We just talked about Dr. Thompson's study and how important it is for patients to be vaccinated. We do understand that not all patients were capable or didn't have the opportunity, but nonetheless, we asked the question and we found that 77% of participants received a COVID-19 vaccination. We asked which vaccination they received, and the majority received either the Pfizer or the Moderna. We also looked into some of the side effects. I didn't list it here, but I should have, because I think it's fun to look at and compare our side effects. But that brings me to my next slide. So some of you may be thinking, why am I just finding out about these results? Why is it taking so long for me to participate and then get the results back? Because it is our goal to share the results back with the patients. Actually, that's our primary goal. We want the patients to know the results of the surveys that they're participating in. But we also want to share our results with the medical and scientific community. So when we publish these anonymized results, so no personal information is shared, everything is anonymized. This is very important. It's almost like a code of ethics that I've taken as a PhD. So everything is anonymized, but so we share the results, and when we do share the results, we give the copyrights to the publisher. So ASH, ASCO, Journal of Clinical Oncology, they have the copyrights for these findings. And through this agreement, we have to wait until after it's published before we can then share it. And this publication process can actually be a little slow. So it goes through a lengthy review process where it's reviewed by experts that validate the methods, the results, and the conclusion. And then they may time it with the particular timing of the release of their journal. So let's say if we did something about COVID and and we submitted it in February, and they're gonna have a journal release that's based around COVID that's gonna be released in May, they may hold off to publish it or release it until that time. But we do have some studies that we've published on, and you can view these. So we're currently working on a design in Healthtree Cure Hub to share back the results with patients. So all these studies that we've done and we have results on, we're developing a page in Healthtree Cure Hub that patients will go and be able to click on and view, and hopefully offer a little bit of interaction. So if you see like a pie chart or some kind of some kind of chart you'll be able to hover over, and it'll offer a little bit more information. We also want to notify patients via email. So it's really important that if you participate, that your email is current so that you can be notified of the results. So we have a lot of studies that we're currently working on. Like I mentioned, the multiple myeloma genetics and real world outcomes. We want to know what treatments are best, what induction treatments are best, what treatment pathways are best. And by best, I mean what's going to give the longest survival time. Our future studies are involving a CAR T and a bispecific study. We're also going to look into fitness and progression and a diet and progression. So you've heard about these, and they are in the works. So not only is publishing the results a little bit time consuming, but so is getting all the approvals and getting through all the red tape to get these studies finalized is lengthy. But there is going to be a diet study and there is going to be a fitness study. Just bear with us a little bit longer as they finalize. And we will notify you. We will send out notification. So we're just at the tip of the iceberg. With the help of patients and coaches, we can make giant leaps in multiple myeloma research and perhaps one day find a cure. As a graduate student, we had a slogan in my graduate class that was working ourselves out of the job. And so it's my hope one day that I don't have a job in cancer research because we've cured it all. So working diligently, and hopefully we'll find some big breakthroughs with all the data that is being shared with us. And from the bottom of my heart, I thank all of you all of the patients that have participated in these studies, that have signed up for Cure Hub, and for keeping up the good fight. I'm cheering for you. And with that, I'll take any questions.
That was incredible, Nathan. I learned a lot. I mean, I'm with you every day in the office, but I learned more today, and it's so exciting, I think, to be able to see the progress we've made. I'll start with a couple of my questions as we wait for patients to enter theirs. We know that CyBorD is usually recommended also, not only because oncologists are kind of unaware of maybe the not so successfulness of it, but also because Revlimid can be so damaging to the kidneys. So those with kidney involvement, extreme kidney involvement, usually are recommended CyBorD. Did your team look into any other induction therapies that didn't include Revlimid, but also, or do they plan to, that didn't include Revlimid for those that might be looking for a more successful treatment? Again, we said it was kind of successful, but looking for a more successful treatment that doesn't include Revlimid. Does that make sense? Does my question?
Yeah, it does make sense. And that's why, I wanted to, I guess I should reemphasize that, while the CyBorD seems to be inferior, there are other variables that we need to take into account. And so if a patient does have, a kidney disease or issues with the kidney, that may indicate or be indicative of a shorter time to next treatment, that marker we're using as our measurement. And so that's something we need to take into consideration. The other thing that we found that is interesting, though, is that so there's two terms that we use in the research industry. We use significance and we use trending. So when something has that probability of less than 0.05, it's significant. If it's close to that but not quite significant, we'll say that it's trending, or it's going in that direction. We found that patients that their insurance had a trending effect on whether they were prescribed CyBorD or not. And so we want the patients to be informed if they do have healthy kidneys, and if a doctor prescribes a certain chemotherapy, if they're informed, then they can say, well, wait a minute, maybe this is an insurance thing. Maybe I should switch my insurance, or maybe I could go get a second opinion or something along those lines. We want the patients to be empowered. That's one of our primary goals at the Healthtree Foundation is empowering patients. And this is one of those components where it's like, okay, self-reflect. I'm healthy. I've just been diagnosed. I have this information that VRD is more effective, but I'm being prescribed CyberD. And then you can proceed forward from
Yeah.
there.
Okay, awesome. That's a great explanation. Thank you. We have Gerarda. She's saying that she has translocation 1114 and 1Q gain. She's nervous about what this means and what kind of maintenance therapy she should be on. While Nathan does have a PhD, he is not a medical doctor, but with that knowledge that you have you studied other patients with this? Sorry, go ahead.
I don't know why there's another. Okay, never mind. We're good. Yeah, so that's a great question. I'm not a doctor. I'm not that kind of doctor. I'm the better kind. There's nothing to be, fear is silly. There's been huge strides that have happened in multiple myeloma. And so I don't want to say that your fear is laughable. I don't mean that. I mean that replace that fear with courage, because there's been huge strides that have happened in the multiple myeloma field in the past 10 years. And so there's so many treatment options that are available for patients that if something doesn't work, then there are alternatives. And we do have stories at the Healthtree Foundation of patients that felt like they're approaching a dead end, and they came to Cure Hub and they identified a new drug and they got put on it and they went into remission. And so just because you don't respond well with one treatment doesn't mean you won't respond well with another. So having a combo of 1114 and a 1Q gain, yeah, I can see that would be intimidating, but you have an arsenal, and I would do your homework to find what's the best option. And we're here in your corner. We're trying to find that answer for you as well. And hopefully we'll find something sooner rather than later, and we can come back to you and say, hey, we just found out that doing X, Y, and Z is going to be your best option. And then you can go and consult your doctor. And that's something I want to emphasize, is we don't want to cut out the doctor at all. We want to make sure they're included in this discussion. So anything that we discover, we want you to consult your doctor and proceed with them. So
yeah, totally true. Gerarda, I would also say there's lots of tools that we provide. Healthtree Cure Hub, if you enter your data, again, that's private when you enter your data, as Nathan emphasized. But one of the amazing features that Healthtree Cure Hub has is personalized treatment recommendations from multiple myeloma specialists that you can then print out and take to your doctor and say, hey, this was recommended through Healthtree Cure Hub, and I really want to consider one of these treatments as my next option or as my maintenance therapy. Another suggestion that I have is clinical trials. If you have these features that are standard high risk, then you would want to go intermediate high risk. Then you would want to go to again, Healthtree Cure Hub. And when you enter your information, it will also give you a list of personalized clinical trials that are open to you, including maintenance therapy clinical trials that are open. That's another option. My third suggestion is please see a multiple myeloma specialist if you aren't already, and ask them this question. This is exactly the kind of question that they're looking for, that they want you to ask. Here's my situation. What kind of maintenance therapy do you recommend for me? Again, just to emphasize the clinical trials, we know that Revlimid is normal for maintenance therapy, but there are other options being tested as well. It's an exciting time, as Nathan was saying, to be in the world of myeloma. Obviously, we would never wish it upon anyone, but if you're going to have a cancer, the multiple myeloma specialists say myeloma is the one to have because of the amazing strides that are being made in the research field. One of your last slides, Nathan said, perhaps we'll come to a cure. I'm confident that we will. It's just about the timeline. So if we can have more patients involved in the research and getting that real world data, these multiple myeloma specialists are so hopeful. And again, working ourselves out of a job, but we need the patient's help in order to contribute to this myeloma research so that we can get closer to that cure and not spend 2 or 3 more decades searching for the cure, but shorten that time thanks to patient involvement. So that's all I was going to say. We'll be waiting if anybody else has more questions. I would ask, Nathan, you talked about that it takes a little bit to be approved when they're looking for like the fitness and the nutrition study approval. Talk a little bit more about that process. Why does it take so long, and what are the steps that those multiple myeloma specialists are taking?
Yeah, so there's a lot of like ethical concerns. So make sure that everything is ethical. So actually, let me back up. So first, it starts with the plan. So we work out an outline of what our plan is going to be. Work out all the details. We want to make sure that we don't have to repeat this because of an error in our planning. So we thoroughly plan. And then after we have a plan, we then discuss the budget needs. So how much is this going to cost? And as much as we'd like research to be free and not cost anything, that's not realistic. So we then start to work out a budget. And then, okay, this is too much. We need to cut some costs. What can we cut? Or, okay, this is too low. What do we need to add? And so we find that sweet spot of where it's affordable, but yet we're answering all the questions that we need to. And then we get the money. So if it's donated to us, that's probably the fastest way. That's fantastic. But otherwise, we have to reach out for grants and apply for them. And all grants are competitive, so that's the process. And if you get turned down, then you apply for another one, and you just keep applying until you get awarded. Once you get awarded, you then go get approved. And this is like it's a government rule that you get approval from an internal review board. You might have heard of the term IRB. And the IRB just makes sure that everything is ethical. So we send them that our planning, our funding, that we have done all of our, we've dotted all our I's and crossed all our T's. And they make sure that it's ethical. And if it's not, they reject it. They say, you can't be done, you can't do it. If it is, then they approve it. And then there's oversight. And so oversight is just that they keep a tab on the project to make sure that everything is going as we written out or as we wrote it. So, I grew up on the East Coast, and I suppose that those that are from the East Coast may be able to relate, but I grew up in the East Coast, and I felt like everything was really fast. Like it was just fast paced. Like if you needed a meeting with someone, you talked about meeting with someone that same day or the next day. And then when I moved out to the West Coast, it was much more chill, especially in Arizona. In Arizona, you would say, hey, can I get an appointment with you? And they'd say, yeah, how does 2 weeks sound? And I'm not talking doctor's appointment. I'm talking like coworkers. And it's just, everyone's so chill. And I feel like this research process has taken that West Coast mindset of like, yeah, how about we review it in a month? So it's a slow process, and unfortunately, but it is inching along. We are getting closer.
Yeah, awesome. And thankfully, with the MCRI within Healthtree Cure Hub, we're able to do things a lot. Even though it is a slow process, it's a lot faster than it would have been
Yeah.
if it was outside of Healthtree Cure Hub. So that's nice. So you were interested in switching from like in the lab cancer biology research to data analytics. Talk a little bit more about why you wanted to make that change and maybe which one you prefer.
Yeah, so benchside or working in a lab is slow, and it's a good thing that it's slow because you need to be very thorough. Everything needs to be verified 2 or 3 times.
Yeah.
And so you conduct one study, you have a positive result. So you conduct it again, you have a positive result. You conduct it a third time, and it's a negative result. And so then you start to second guess. And so it's just a very thorough process, and it makes sense. Like, you don't want shortcuts in research. But I like that. I like that discovery aspect. And so that was really enjoyable to me. But I spent 6 years on one question as a graduate student. And that was a little bit too slow for me. So working with data and doing like these analyses is much more faster. You can ask a lot more questions and get to the bottom of a lot more get to the answers of these questions a lot faster. And that maybe it's my roots of growing up on the East Coast, is this, I like the faster pace. It's more exciting to me. And then, when I was looking for a job, and I said it was, serendipitously that I came in contact with the Healthtree Foundation. It was really just a match made in heaven, because not only was it something that I was looking for, but it's such a wonderful foundation.
Mhm.
I did interview at other places, and I loved the Healthtree Foundation. And it was, I can tell you now, over 2 years into it, that it was the correct choice. Like, it's just been a fun, fast ride, and it's exciting. So I would say both have their pros. I haven't really encountered a con with this data analysis yet, because maybe I'm still in that honeymoon stage. I just really love it. But the cons of the bench side is that it's very slow, and I wanted to transition from there.
Okay, that makes sense. Um, in one of the slides too, you mentioned coaches and patients will be able to help bring about this cure. Um, how can the coaches or the myeloma coaches that we have a myeloma coach program, how can they play a role, and what is their role?
So the coaches can be an example. Like, seriously, if they led by example. So if they received, so if you're not familiar with the coach program, coaches are kind of like mentors, and they take new patients or newcomers to Healthtree Cure Hub, and basically kind of take them by the hand and either just talk to them and just be there for them, or they can guide them through Healthtree Cure Hub. And I would love if they went that extra mile and guided them through Cure Hub and say, and this is where you can participate in research. And, I participated in this study, and this is what we found. And if they, if they shared the same enthusiasm, it would really help in the recruitment process of getting patients to engage and participate. And also just being familiar with with Healthtree Cure Hub, it would be really beneficial, because if a new patient has a question like, oh, I heard you can participate in research or, find clinical trials, and they're not familiar with it because they haven't experienced it, then we may not get that one extra participant or something.
Yeah,
Everyone matters.
awesome.
Yeah.
That also kind of brings up the point that it's important for us to share with our support groups and our myeloma connections and our oncology centers and our specialty centers. Like, when we do participate in a study, I know this nutrition study is one that I'm really excited for to share within my nutrition and wellness chapter. It's just, word of mouth. Even though we live in this digital age, word of mouth really can serve as one of the best connectors for furthering myeloma research. As we talk to our friends, we talk to our myeloma communities and contacts and say, this is what I'm doing, here's what we can do together. As you were talking about Healthtree Foundation, one of our main goals is to empower patients. And what better way to empower patients than put in their hands the responsibility of participating and contributing to key myeloma research. So that was one of my thoughts that I had. Any more patient questions? We're excited to answer them. What are you looking forward to in the future, in these next couple months, Nathan?
Well, so this is a really important question to us, is which treatment pathway is best or optimal for patient, depending on their genetics, cancer genetics. And that's really exciting. These are questions that are basically difficult to answer. But we're in a unique situation where we can answer them, and we can provide some valuable information to the research community. So I'm really excited about that. And we are making headway. So as I introduced our team, I'm working with Emily, and we have run into some dead end where we've asked questions, we've analyzed it, and we really haven't found the results that we're looking for. So we go back, and if you're familiar with the scientific process, you start with a hypothesis, you conduct your experiment, you look at your conclusions, and you either, agree with the conclusions, or you have to go back to the beginning. So it's just this cycle process until we finally get that one result where it's like, this is it, this is what we're looking for. So we are making progress. We are, it's an exciting study. So I'm looking forward to that one. Another study that I'm looking forward to is this CAR T study that we're going to be conducting. So this CAR T study is, if you're familiar with it, CAR T is both a clinical trial and some of it has been approved. And pharma companies monitor patients while they're in the clinical trial. We want to monitor patients post-clinical trial. And that will be really beneficial. It's unknown. We don't know what the long-term effects will be. So we want to start capturing and gathering that information. And then a third option, or a third study that we're going to be conducting here in the future, is a blood pressure study. So there has been some preliminary data that has come out that has said that if you're on blood pressure medication, like a beta blocker, that it can be beneficial in delaying multiple myeloma progression.
Oh, wow.
So we want to actually examine that, but also examine if that has to do with just having a normal blood pressure. So I'm currently putting together a protocol of a study to look into that, and we'll either fortify the preliminary data that has been found by another group, or we'll find another conclusion of our own. And so we're excited to do that. So be on the lookout for that one. That one will be exciting. We may be able to do it retrospectively. So basically based off of the blood pressure records that you have in your medical records. If it's not enough data, then we may, we're still working on the details. We may either send a cuff, a blood pressure cuff that patients can take their own blood pressure, or just record it over time as you go and see your doctor or something. So we're still working out those kinks, but we're anticipating November of when we'll release it. So
okay, that's exciting.
Yeah.
That's exciting. I'm excited to see those studies in the future and what they tell us, and how it accelerates myeloma research. So thank you, Dr. Sweeney, for joining us today. We will finish with just a couple of outro announcements, and then we can get going with the rest of our day. So our next Connect with the Myeloma Crowd chapter meeting will be on October 20th, 2021, and we will be talking about Healthtree University. Cindy Shimoleski and Paul Ahlstrom will be joining us to talk about how to educate ourselves about myeloma. As Nathan and I were mentioning, empowering yourself as a patient is key in getting the best care and in being more aware of what's going on with you or your loved one. So how can you do that through Healthtree University? It's actually really easy, and we're excited to show you how and show you key classes that you should watch in order to improve your education, continue to improve your education, I should say. You may be interested in other Myeloma Crowd community events we have coming up. Today at 3 p.m. Eastern is our Mountain West Myeloma chapter event. We will be hearing from multiple myeloma specialist Dr. Godara from the Huntsman Cancer Institute about how we can raise awareness regarding what relapsing or becoming refractory really looks like. The 21st at 1 p.m. Eastern is our Myeloma Financial Coach chapter event. We are going to be discussing the Medicare open enrollment, what we need to know, with Myeloma Financial Coach Diana Valentine. At 6 p.m. that same night, the 21st, is our relapse refractory myeloma chapter. Multiple myeloma specialist Dr. Manny will be joining us to discuss the highly debated question of maintenance therapy. Who is it for, and how long should patients continue with it? On the 22nd of September at 1 p.m. is the Selinexor Support Group chapter. Todd Foster, Nathan and I's co-worker and the head of product at Healthtree, will demo a Healthtree Cure Hub feature called Patient Solutions that shows anonymous patient data who are on selinexor. What side effects did they have? What did they do to improve these side effects? And did these remedies work? I'll say, even if you aren't on selinexor, that is a fun chapter event to attend, as Patient Solutions not only talks about selinexor, but other drugs, even dexamethasone. And you can look, what were different patient side effects and what did they do to overcome these solutions, and were those remedies successful? The link to sign up for any of those events and even more events that I have not mentioned today is found at the bottom of this slide and will be included in the follow-up email within 48 hours of the event's conclusion. Another thank you to our sponsors, Bristol Myers Squibb, Takeda Oncology, Karyopharm Therapeutics, Adaptive Biotechnologies, Oncopeptides, Janssen Oncology, AbbVie, Sanofi, Amgen Oncology, and Genentech. And thank you to each of you for helping us build a strong myeloma crowd community. I appreciate you so much and hope that you have a great rest of your day. Thank you.